My name is Temidayo Abe. I'm an internal medicine resident at Moore School of Medicine in Atlanta, Georgia. I'm presenting a clinical research abstract on a paper that is titled "Diabetes is associated with composite cardiopulmonary complications among COVID-19 patients." I have no disclosures. Starting with our introduction, COVID-19 has become a major global crisis. Studies have demonstrated cardiovascular complications among COVID-19 patients, including sudden cardiac arrest, arrhythmias, and myocardial infarction. Patients with underlying cardiovascular disease are more likely to have these cardiovascular complications. Um, but cardiovascular complications in diabetes patients have not been well studied. In this study, we aim to investigate cardiovascular complications in COVID patients with diabetes compared to those without diabetes. Going to our methods, we identified 126 patients with laboratory confirmed COVID at our institution from April 1st to April 30th, 2020. Among these 126 patients, 54% had diabetes and 46% were without diabetes. We compared their demographics, comorbidities, and study outcomes between patients with diabetes compared to those without diabetes. Our study outcome included acute heart failure, acute myocarditis, acute myocardial infarction, new onset atrial fibrillation, and composite cardiopulmonary endpoints. Acute heart failure was defined by patients with clinical and laboratory evidence of volume overload and echographic changes of systolic or diastolic dysfunction. Acute myocarditis was defined by patients who had troponin that was elevated, troponin high to be specific, that was elevated over the upper limit of normal. Acute myocardial infarction was defined by the fourth universal definition of myocardial infarction, which was released last year by the American Heart Association, while new onset atrial fibrillation was defined by electrocardiographic changes. Composite cardiopulmonary endpoints include all these individual outcomes and ARDS. After we compared using descriptive statistics, we then used multivariate logistic regression to estimate the study outcomes in people with diabetes compared to those without diabetes. Going to our results, the mean age of our study sample was 62 years plus or minus 14, and table 1 year is where you can find the key demographic and comorbidities difference between both groups. The patient with diabetes had higher rate of comorbidities, including hypertension and congestive heart failure. For our study outcome, unadjusted study outcome, acute heart failure, acute myocarditis, acute myocardial infarction, and composite cardiopulmonary endpoints were all significantly higher in diabetes patients. In the logistic regression, the adjusted odds ratio for acute heart failure, acute myocarditis, acute myocardial infarction, and composite cardiopulmonary endpoints remains significant. The adjusted odds ratio were 7.1, 3.1, 4.4, and 2.6 respectively. We suspect that these cardiovascular complications in COVID-19 patients with diabetes could be explained by the higher rate of comorbidities in diabetes patients and exaggerated immune response in diabetes patients. Our study must be interpreted with caution because over 80% of our study population were African Americans, which limits the generalizability of our study, and also as our sample size was very small. This, in conclusion, this study demonstrates that diabetes is associated with worse cardiopulmonary outcomes in COVID patients. Further research is crucial to understand the pathophysiologic mechanism of COVID-19 in diabetes patients in order to devise treatment strategies and to mitigate complications. Thank you.